everybody. Welcome back to the living room. Thank you all for coming tonight. Thank you, everybody online, for signing in for what I believe to be one of the most important educational evenings that we will have. As you guys will notice, Bonnie, AKA Mom, is not here tonight. She is in Indianapolis. She met with Lily today, I think. I think she was meeting with Lily today. So hopefully she figured out how to sign in from there. And I'm going to make a little daughter joke because I can. Tony's not with her, so she may not be able to figure that out. So I'm keeping my fingers crossed she's with somebody that will show her how to do that, and that she'll be able to sign in. So thank you all for coming. You know, tonight we're talking about what I like to call supportive care, because I know from talking to most of you, when we use the word palliative care, it tends to kind of make the hair on the back of your neck stand up. We've got Dr. Bonomi from Rush, all the way from Chicago. He flew in today and is flying back out today. So that's a huge commitment on his end. He is not only an expert in lung cancer, but an expert in the topic tonight and a true believer in what we're doing. So I want to start with an around the room so that he can kind of know who you're talking to. And at the end, I'm going to ask Dr. Bonomi to kind of introduce himself, give a little bit of his background, and then we'll jump right into tonight's topic. So, Fred, I'm so happy to see you sitting up front today, because you typically sit in the back. And this is why people don't want to sit up front, because then I call them out and I make them feel uncomfortable. But if you would like to start tonight, we'd love to hear from you.
Yeah, my name is Fred Palmer, and I was diagnosed with adenosarcoma in the right lung in October of 2013. I had radiation chemotherapy, and that solved the problem. However, there were signs that it was had spread to the left lung, and that's what we're dealing with right now. I was on targeted therapy, but evidently the mutation was not sufficient to be really treatable by targeted therapy. So now I'm on chemotherapy again, carboplatin and pemexetrid, and it seems to be working, because I noticed results within about 24 hours after having had the chemotherapy in terms of swelling of a lymph node. So hopefully that we're on the right track, and I'll be going for my second round of chemotherapy on Thursday.
Good. And you tolerated your first cycle?
Yeah, it was a lot rougher though than the first cycle than my previous cycle of chemotherapy with radiation.
Yeah.
It was, this is a little rougher, but seems to be working very well.
Good.
That's the latest update.
Well, we can talk about trying to help get you through some of those rougher parts tonight. Thanks, Fred.
Hi, I'm Sally, and I entered the International Early Lung Cancer, I can't remember what the rest of program. Whatever, ILCAP, and in 2004, and because I was at very high risk for lung cancer, and I was in the program for 5 years before I have many nodules, and I was in the program for 5 years before one of them grew, and they were suspicious it was lung cancer, and it was found very, very early, so thank God I went into a program for early detection, and I had my right lower lobe removed in 2009. I was staged 1A, and I've been doing great ever since.
Thanks, Sally.
Hi, I'm Jane, and I was diagnosed with stage 4 non-small cell lung cancer in May 2015. I'm coming up to my 1-year anniversary. I was tested for mutation and was told that I was an exact match for Tarceva. I have been on Tarceva since then. Happily, the main tumor is half the size it was initially, and my most recent scan, which was in mid-February, showed I'm totally stable, for which I'm eternally grateful. My current challenges are primarily dealing with the side effects of the Tarceva.
And Jane, you and I met
we met at the UCSF Lung Cancer Support Group.
Yeah, it was about 3 months ago.
Which was
right?
great.
Yeah.
I love UCSF.
Yeah, they're great. I'm
They're
so happy
it's
that,
wonderful. I feel very, very taken care of.
good,
Yeah.
good. And I'm happy you came down to join
Thank
us
you.
live
I'm
tonight.
happy to be here.
Good. Folks? No? See, I knew it.
Hi, my
Oh.
name is Linda.
There you go. Go.
This is my husband Dennis. We drive up from San Diego for this meeting because it's that worthwhile. Our daughter was diagnosed with stage 4 lung cancer in September of, I have to think now, 2009. No, 9. And,
Yeah.
because, anyway, 2009. And so she's doing very well. She's stable. She takes chemo every day, but the pill form. And so that's keeping her stable, and she's adjusted to that. And so we're very hopeful and grateful. Thank you.
Thanks, Linda. And if you guys didn't hear that first part, they drive up, the Musials, who are, the extended part of the ALCF family, drive up from San Diego, and they try to coordinate meeting with family, right, with these meetings so that they can come and participate. And we couldn't appreciate you guys making the effort.
Hi, I'm Doris, and I was diagnosed with stage 4 lung cancer, adenocarcinoma, in August 2015. And I was tested genetically, and the findings were the mutation will respond to Tarceva. And I've started taking Tarceva in September, and I've had follow-up scans where results showed no growth in terms of the stability of the cancer cells, and dramatic clearance of the nodes. And right now, I'm also dealing with the side effects of Tarceva, my Tarceva finger, and yeah, but happy that I'm doing well and quite stable.
Great. Thanks, Doris.
And this is my husband, Maynard, who's my caregiver.
Hello. My name is Charles Bain, and I was. Hello?
You're good.
Oh, it's working? Okay. I was diagnosed about the same time as Doris for stage 2B lung cancer at that time. And then I went through chemo treatments, cisplatin, I think it's called Vinorubin. Then they were going to do surgery in March. But unfortunately, when they looked at my lymph nodes, they found cancer had spread over there in my mediastinal middle chest area. And then they suspended the surgery. And then they elevated my grade up to stage 3B. And then now they're putting me on chemotherapy and radiation. And I'm dealing with more side effects than I had before, because I have radiation burn all around me. I got my lung is inflamed. I'm coughing more, so I take Robitussin, and then also, well, the chemo somehow this time I'm on Taxol and I think it's carboplatin, and that's so far they're giving me half dose while I'm on radiation, but I hope I won't have too many side effects from the full dose, which is probably going to happen in a couple weeks from now. So looking forward to any tips that I can learn today, so appreciate it.
You will get through it. You just gotta get through it, and then they'll be behind you. It's not fun, though. I was diagnosed in 2010, and I did test positive for EGFR, but I did have radiation and chemotherapy. And then as a maintenance, I've been on Tarceva since then, and it's been doing its job for me, so I'm very blessed. Do you want to say?
I'm Tina's husband, and it's been a long but good 5.5 years since she was diagnosed, and she's had totally clear scans for almost 5 years now, and side effects are not too bad, but she does have a few, but she's been dealing with them. But I think her hair looks great. She doesn't think so.
There was that handheld, I think we stuck it, there we go. Yeah, that one. Doris, yeah, perfect. That way we can just pass it on down the line.
My name is Tekla. I was diagnosed in 2014 with stage 4 adenocarcinoma and did carboplatin and pemetrexed in the trial at UC Davis. And then 2 months ago, I was diagnosed with bladder cancer. So now I'm undergoing that treatment, and hopefully it'll work.
And I'm Steve, Tekla's husband.
Yeah. No, you don't have to, but you certainly can. No? Doesn't have to go, doesn't have to go, doesn't have to go. Everybody done introducing themselves? Does anybody online, I think there was somebody online that wanted to give a big shout out.
So the Eggerts wanted to say, give you your shout out, but they wanted to say you're a fantastic doctor. You don't leave his office ever not feeling calm and confident. He's truly a human that cares about his fort. And and then we also have Big Daddy on from Louisiana. We have Rick in Florida, Liz in Fort Myers, and Penelope's on from here.
Oh, good.
So
Good,
they all
good.
said hi. Thank
Good.
you.
Hi, everybody. And so I just want, before Dr. Bonomi introduces himself, to all of those that I know are watching online, you can, of course, stay anonymous online, but if you would like to use the chat feature, because I know it can be a little bit confusing about how that works, just in the upper right-hand corner, just sign in, create an account, and it'll bring you right to chat. So if you do have any questions tonight, we can be sure and ask them for you. So with that, I'm going to ask Dr. Bonomi to just give a brief introduction of himself, and then we'll jump right into tonight's topic.
So first I want to say hi to Ron and Barb Eggert and tell Ron that it's a privilege to be one of your doctors.
Aww.
I learned that back in medical school. When somebody puts their trust in you, it's a true privilege, and you should make sure that you live up to the expectation. So I'm actually been an oncologist now for 40 years. And when I started out, I was on the ECOG Lung Steering Committee because nobody else wanted to do it from Rush. In fact, at that time, there were very few doctors practicing medical oncology, specializing in lung cancer.
Can you tell everybody what ECOG is, just
Oh, yeah.
for those who might not know?
ECOG is the Eastern Cooperative Oncology Group. There are a number of large cooperative groups around the country, and academic medical centers and community-based medical centers collaborate in this group, and they offer clinical trials to patients. And in fact, when I started out, that was the main way that people could be involved in a clinical trial. Now, there's been an explosion of drug development, as you know, and it's been driven primarily by industry. Pharmaceutical industry has driven this exposing the things they were talking about today, the EGFR inhibitors and ALK inhibitors. These were developed in the companies that have a laser-like focus. They see a potential target, and they bring those drugs to the marketplace, and then people can benefit from those. So it's the amount of progress I've seen in these 4 decades is truly amazing, truly amazing. So anyway, I'm at Rush University Medical Center. I've been the director of the Division of Hem-Onc for about 24 years. I'm going to step down from doing that, and part of the reason I'm going to step down from doing that is I want to spend more time doing clinical and translational research in lung cancer. Plus, time to pass the baton. That's the other part of it. But anyway, I'm looking forward to that time when I'm going to have more opportunity to devote my efforts to lung cancer research.
That's great. Thank you. Thank you. So with that, I'm going to jump right into tonight's topic, and we're going to just do a very basic, what is palliative care? Give us sort of an overview of what palliative care is. And you and I have had a chance to talk, and I've talked to these folks, you know, one-on-ones and in this very room ad nauseum about palliative care, and it's not what you think it is, right? So can you give us a
Absolutely.
little?
So actually, it starts from when I was a fellow, one of my mentors, and we talked about this earlier, said, well, what are we trying to do here? And of course, I'm giving this scientific thing. We're trying to figure out cancer and new treatments. And he said, no, we are trying to relieve suffering and prolong meaningful life. That's what we're trying to do. And of course, I've never forgotten that. It's kind of been my personal mission statement. And that leads into what is palliative care. Palliative care is the relief of symptoms. Palliative care is the relief of symptoms that are coming because of the cancer. It also is management of the side effects. As I went around the room here, we hear about somebody getting chemoradiation, truly a very hard treatment, trying to manage those side effects. And the management of the side effects is a very much of a team approach. It's the primary oncologist, frequently a nurse practitioner or physician assistant who works with the physician. It's the treatment room nurses. And then it also is now, within the last decade, there's a large number of palliative care doctors. And so at our institution, the way it works, you know, the initial stuff is done, primary oncologist, the nurse practitioner, the treatment room nurses. And when we are not feeling that we are managing either the symptoms from the disease or the side effects from the treatment, we get a consult with from the palliative care doctors. And they come in and they help us with this. Everyone has, you mentioned your treatment with the pemetrexed and carboplatin. So was it nausea? Was that the primary symptom?
Nausea, fatigue.
Yeah, fatigue. So fatigue is a big factor. Part of it is even just education. So with pemetrexed, there's a really kind of a common sequence that happens, pemetrexed and carboplatin. You get treated, the next day, frequently people feel like fabulous because part of the anti-nausea treatment they get is a cortisone type of medicine. Then the next 4, 5, 6, 7 days, like, ooh, I'm kind of tired and I don't feel like eating. Then that kind of wears off. Sometimes we use for that a tapering dose of steroids to help that. So those are things you talk to your physician and the nurses and they'll manage this for you. But those are the types of things. Same thing with the EGFR inhibitors. The rash can be a big problem. Cracks in the fingertips can be a big problem. So again, the team tries to manage that, but if we're not succeeding, then we get the dermatologist to help us. Same thing, cancer is, there's probably no word that's more scary and anxiety producing than cancer. And so, you know, we work with the patients, we're looking at all the emotional aspects, but we also work with psychologists and sociologists and, you know, social workers that help us to manage the things. So it's a truly, it's a team approach. Multidisciplinary, and in fact, in lung cancer, all academic medical centers have multidisciplinary teams that take care of it, and there are, at least in our area in Chicago, increasing teams, multidisciplinary teams that are delivering care for lung cancer patients in the community-based setting too, and we collaborate with them. So the palliative care is relief of symptoms, relief of distress. A lot of people say, oh, that means you're giving up on me, we're not going to do anything to treat the cancer. No, we're going to treat the cancer, but we want to take care of the entire patient. And that includes, if they have trouble with diabetes, we call an endocrinologist to help us. Some of these new immune therapies are having lots of unusual, like hypothyroidism, underactive thyroid. We get the endocrinologist to help us. So it's a team approach. It should not have a negative connotation.
So I think when we look at palliative or supportive care, there's a few different areas, right? There's the physical, the emotional, the psychological, the spiritual, and the social. And so it's really about treating the whole person. And,
yes.
And we'll get into kind of what you were talking about a little bit ago about who should receive palliative care, and I think I know what your answer is going to be. But let's start with some of the physical sort of things that might contribute to one's need for palliative care. So, like, we kind of have this laundry list here, and I'm sure there's way more than I have on this list. But we're talking about nausea, pain, rash, shortness of breath, fatigue, loss of appetite, particularly in conjunction with anorexia or cachexia, which I actually want to have a larger conversation about because I think it's so important. But when we're talking about nausea, pain, and rash, this is areas where I hear patients all the time, what can I do? And the docs are prescribing, topical creams for the rash, for example. And in this room, I think patients have learned a lot about, well, what are some things that I've done for my rash, right? That's not just a topical cream that have really helped. But those are all sort of things that kind of fall into pieces of the pie when we're talking about this palliative or supportive care. Some of them tie into this, like I said, this anorexia, cachexia type thing. And I know some of you who have been here for a really long time know what I'm talking about because we've talked about it in the past. But in particular, when we're talking about fatigue and loss of appetite, what are we really looking at? Because for the most part, docs will prescribe steroids and Megaze and all of these sort of things because of what they thought was maybe happening. But what is actually happening?
Okay, so we call it the anorexia cachexia syndrome, and it is very, very common in lung cancer. In fact, before I came here today, early this morning, I saw a woman she retired on January 31st. She ran a travel agency. She went down to Florida, and 3 or 4 days later, she just said, "Man, I got this profound fatigue and weakness. My appetite went down, and I lost 20 pounds during the last several months." And she went to see her doctors, and they checked a number of things, and eventually found out she had lung cancer, which was widely metastatic, adenocarcinoma. But the dominant feature of her illness from the very first day was loss of appetite, loss of strength, and loss of weight. And so what's happening here? Well, there is probably a relationship between the tumor and the good cells that are trying to fight the tumor, and even the good cells do some things that cause the muscle in a person's body to actually decrease. I was actually, I've only become interested in this within the last few years, but for years, I forgot one of the things that one of my medical school professors told me, which is listen to the patient. He or she is telling you a diagnosis. What I would hear over and over is big, robust guys come in and say, "Doc, my arms are gone, my legs are gone," because the muscle is just melting away. And so this cachexia syndrome, it's a muscle wasting process. And in fact, the tumor is actually kind of starving the person. Muscle breaks down. The tumor uses that as an energy source and as molecular building blocks to build more tumor, grow more tumor cells, and to spread and to do bad things. So we now are looking at ways to try to intervene, and many things have been tried over the years. Back early in my career, I used to treat a lot of patients with Megaze for prostate cancer, breast cancer, and for loss of appetite. I was nicknamed the Megaze maniac at one time. But here's what was wrong with Megaze. Megaze did increase the appetite in some patients, but it did not increase, we didn't realize it didn't increase the muscle mass. It just increased kind of fat, and actually some of the weight was just fluid retention. And prednisone is another thing which can be used to palliate lots of problems in cancer patients. But when we use it to try to palliate the loss of appetite, it does work in some patients, but it actually causes breakdown of muscle. One of the biggest side effects that we see in patients that are on prednisone for a long time is when we get up out of a chair like this, we use our hip girdle muscles, we use our thigh muscles. Well, when somebody's been on prednisone for a while, they have to get out of a chair like this because it makes these muscles actually atrophy, and it makes them weak. It recovers when they come off of it, but it takes a long time. So the things that we've tried have not been good. Marijuana people have tried, again, really not very effective. And so we do have some really new things coming now. One of them is a drug called anomorelin, which does two good things. It stimulates appetite, and it also stimulates muscle mass in patients. And the results of two very large studies, international studies, were published in the prestigious journal Lancet Oncology just within the last several weeks. This drug is not yet approved here. We're hoping that it will be approved because lung cancer patients who have stage 4 disease throughout the course of their illness, almost all of them are going to deal with anorexia or cachexia at some point. And having this type of thing to help to reverse that and to help patients feel better is going to be a very useful thing.
So I think that a lot of people think it's actually the treatment that's causing the weight loss. And I think what I hear you're saying is actually the cancer that's causing this muscle wasting or cachexia.
Yeah, and the treatment can too. For instance, our gentleman over here that's getting radiation and chemo, did you have trouble swallowing during the course of this? Did it hurt?
Well, what I do is, I found that when I swallow, I had this burning sensation.
Yes.
But then, when they do the radiation on me, I kind of use my chest muscles, because I can feel it coming into my trachea. I just move it a little bit, like so, and then that's how I kind of stop that soreness.
Yeah.
But,
So sometimes that type of treatment can actually cause people to lose weight because they can't eat, because it hurts, and so they don't eat as much. But we actually have written several papers, or small papers, where we've shown that people who get treated with combined radiation and chemo, those who gain weight survive a lot longer. And basically what's happening is the tumor responds, and that reverses this cachexia thing, and they can actually put weight on, and there's starting to be some preliminary studies that suggest they also put on muscle mass. So control of the tumor will reverse that. But there's a lot of patients where we only get partial control, so anorexia, cachexia is still a big part of the symptoms for them, or it's not being controlled, and then the anorexia, cachexia is frequently a very large part, one of their dominant symptoms.
So is this something you would use when we're talking about loss of appetite? And then we're talking about nausea. So as long as we're controlling the nausea, these drugs will counteract the loss of appetite? Is that
Well, if the nausea is from the treatment, that will help, but there still may be the underlying loss of appetite because of the cancer.
Gotcha. So basically, regardless, and this is, because we've sort of identified that this is primarily the cancer that is driving the anorexia, cachexia, regardless of treatment that you're on, it's most definitely something you need to talk to your doc about. And I guess, is there a way to differentiate between weight loss, be it fat and water, and muscle wasting? Is it strength?
You really need to do a test for that, either the DEXA scan, or there's a fancy way with a routine CT scan. You can measure a person's muscle mass, but you need some special software, and it's not something that's done on a routine basis. But what you do see, what you just said is, doc, my muscles are gone and I'm weak. I don't have the usual strength, including just walking around.
Yeah. Well, it's interesting, and I'm going to speak for my mom at this point, and then if anybody's experienced it, I'd kind of like to hear a personal experience. But I remember when she was going through her treatment, and she had actually, I don't think my sister's here to help me, but I don't think she'd lost a ton of weight prior to diagnosis. But it was like post-diagnosis and going through treatment and whatever. I mean, it was quick and it was dramatic, right? And it wasn't until she became aware of this whole idea about cachexia and this muscle wasting that it kind of made sense to her, like, oh, no wonder it was hard for me to get up the stairs, or no wonder it was hard for me to pick up, a bag of groceries or that type of thing. Is this something that docs talk a lot to their patients about? And I'm not necessarily talking about in the academic centers. I'm talking about, where most patients are seen in the community. Is it something that they're really aware of? Is it something that they are looking out for? And because we're not approved yet here in the U.S., how do we help these patients?
Okay, well, I think that every oncologist is aware of this. And we actually have a paper that's been submitted, and one of the reviewers said, well, everybody knows about this. But then somebody else said, yeah, but nobody's written about it. So it really, the doctors who take care of the patients, they know it happens, but there's not been really a lot written about it. There's been a lot written about if you have lost weight, the prognosis is worse, but there hasn't been a lot written about what to do about it, and if you do see weight gain, that it can have a positive, it's associated with a better outcome. So I think so when you're dealing with this, it's multifactorial. So we talked about the tumor and the inflammatory cells causing a muscle breakdown. But the other thing that happens in lung cancer patients frequently is their taste is affected. Things don't taste the same. People who love red meat say, I can't stand it. I used to love a steak, can't do it anymore. And people that like sweets say, it tastes too sweet to me now. And the other thing we hear, and there's a physiologic reason for it, is, breakfast is a pretty good meal. Lunch, not so good. Supper, the worst. And, or I really feel hungry, and I eat the first 3 or 4 bites, and I'm full. So why does that happen? Because the peristaltic waves that move the food through the intestinal system are slowed down by the cancer. Probably some chemical factors that they make. We don't know exactly what it is. So in just some common sense things that we recommend is eat smaller amounts more often. Don't force yourself to eat the thing because, this steak because you think you need it. You can't do it. Maybe have some yogurt, have something lighter. People tend to be able to eat lighter things more readily than heavy, like meat and potatoes. That could happen. Dinner is the biggest meal for most people in this country. That's not the right thing to do when you have this syndrome. Things like anomorelin, increasing your appetite and stuff, can reverse that. Treatment of the cancer can reverse that, but it's very common. I would say every day in my clinic, and I have a clinic 4 days a week, there's somebody saying, either the patient saying, I can't eat, or the family saying, we can't get him or her to eat anything. And it causes a huge amount of stress between the patients and their loved ones, because loved ones want to help. Hey, I made you your favorite cake. I made your favorite whatever, pasta. And you didn't eat any of it. And they think they're not trying. It's physical. They can't do it. It doesn't taste right. They don't have as much saliva. Their mouth is dry. The food isn't going through the intestine fast enough. And so recognizing that can help to relieve some of this, kind of contentious stuff that's happening. Because if people want to help, they feel like their loved one isn't trying, but they're trying. They can't do it. It's physical. So a medicine that would reverse that would be very, very helpful.
So a couple of things. So number one, talking about that, it's actually a physiological response. The patients literally cannot do it. We're hoping that the current drugs on the market are sort of helping with that, but the ones coming down the pike will definitely help with it.
Yeah.
As caregivers, I know in talking with caregivers in the past, they do feel helpless, and they're at the store every 5 minutes trying to find something that the patient will eat. So is there, I guess, what advice would you give to the caregiver and to the patient? Because the fear is now the anorexia actually becomes worse from the cancer, because
Yes, right.
what they used to call consumption, right, is ultimately what becomes more dangerous than the cancer itself.
Yes, it's true.
So
I think the thing is just for the caregivers to understand that this is a physiologic process that's being caused by the cancer, and try to be supportive, try to buy the things. I tell people, you know what, if all you feel like eating is cookies, eat the cookies, because it's better to get some calories in. The other thing we should also talk maybe a little bit about is there's a lot of stuff out there about diet. Don't eat sugar, it feeds the tumor. Don't eat dairy products. Don't eat red meat. I tell my patients, don't listen to it. When you're on this, we want you to do the best you can to eat, protein and calories from all types of foods. And so I've had some patients, one of them was a physician, a very smart guy, an ophthalmologist. He decided he was going to starve the tumor. He was not going to let the tumor have any sugar. So what happened is he went on, virtually no carbohydrates, and very rapidly lost about 20 pounds, and his muscles all withered away because the tumor broke down the muscles, and they made the sugar from that. And so that doesn't work. You have to either reverse the tumor or do a intervention like anamorilin to reverse it. That's what has to happen. Prednisone and the magistral acetate megase, they don't do that. They don't reverse the process.
So, and we've said this here before, and I want everyone to hear it again. The sugar thing is, if you can tolerate it, eat it. It doesn't matter what it is, right? It doesn't matter what it is you're taking in. It's all about the calories that you're able to take in. So do you find in your experience with patients that there are certain things, because patients ask all the time, to your point, this tastes terrible, this tastes terrible. Are there things when patients are on treatment that are more tolerable?
You know, it's different for every patient, but it tends to be lighter things. You know, the red meats and gravies and stuff, that's usually very hard to eat. And so you find what you can eat, and, you know, you can do the supplements like Ensure and so on, but eat what you can eat.
Yeah, I think it's because I've kind of heard the same thing. It's either the more bland, the better. Ironically, I've also heard the spicier, the better.
Yes, that's true.
Right, so it's at one end or the other of the spectrum to try to
It's
find
very
that.
individual.
Yeah.
Yeah.
I remember for my mom, one of the things that she couldn't tolerate that made her more sad than anything was red wine. Because she loved her red wine. And she still felt like, I want to do this, but she's like, it tastes awful.
Yeah, many people say, you know, I used to like to have a drink or a glass of wine. I can't do it anymore.
Yeah.
That's very common.
Do I mean, clearly we all know that that's no longer the case with my mom. She sits here on the third Tuesday of every month with a glass and one after. Are these things that subside? Do they kind of ebb and, flow?
If the tumor's brought into remission, people start to like things again and they gain weight and they can drink alcohol. Yeah.
Is gaining weight the same as gaining muscle?
You know, that, I believe, yes. And we're just starting in our studies, and other people have bits and pieces, small studies, that patients can actually put muscle mass on during treatment. But those are the patients, we believe, where the tumor is either receding or at least being controlled. And it interferes with these mechanisms between the tumor and the muscle mass and the loss of appetite.
Interesting.
Reverses them.
So Tina's kind of to your point, when I think we're talking about like your early therapy, right? When you were saying hang in there, it's horrible, but if you get through it, you can come out the other side, right? Yeah. So what role does exercise play in this? And what type of exercise is too much or not enough? Patients ask that all the time.
So surprisingly, there's very, very little data about exercise in cancer patients. There are some things out in the literature, for instance, in women who exercise a lot, they have a lower incidence of breast cancer, saying that it may have some protective effect. Not everybody buys into that, but I tell my patients that, first of all, we want you to live your life, and we want you to be active, and most patients, what I hear from them is they want to be able to do their usual daily activities. They want to be able to do things with their family, with their friends. If they want to work, they want to be able to work. And so what I tell them is I think walking is a good exercise. If you can walk, I think that's great. You know, it could be even a little amount, but do it. The other thing is some of my patients exercise pretty heavily. I saw a man on Monday. He's on Olympta maintenance. He's having a very good response. He lifts weights. He runs. He rides a bike. He really exercises heavily. And I believe, but we don't know this next part, that people who do some kind of exercise, they do better. Can't prove that. I hope there will be some studies, but I think this combating cachexia by treating the cancer with medications like anamorilin and exercise too are going to be part of the thing that'll help people have better quality of life, and maybe it'll help them to live longer too.
It's interesting. I know I've talked to patients in the past about the exercise thing, and I'm like, even if you don't feel like getting up and walking, like sitting on watching TV, grab a can of soup and just move, right?
Yes.
Something.
Yeah, simple things.
Yeah, simple things.
Yeah, I was going to tell you my own experience because I am an avid fitness person and I go to the gym often. And what I found is that during the treatments is if I can exercise, I still have that appetite. In fact, I've had the opposite effect of I've gained 10 pounds since being on treatment. Not, I think because I'm not as active, but and also sleeping. I'm able to sleep better But when I think there was a time where I was told, well, just cut back, take it easy, just rest. And what I found was that then I didn't have the appetite, then I couldn't sleep as well. So I think there's something to the exercise that helps stimulate appetite, help you sleep better, and then I think it's also good for your circulation and flushing out, some of those bad chemicals that we get too. So I hope there's going to be some more studies on that, because I think there's a lot of doctors in the dark that, they're going to tell me just walk, don't do anything else, but I didn't listen, and I'm glad, because it actually makes me feel better, and so.
Yeah.
So I think there will be more studies, and I think it's really good that you gained 10 pounds. That's awesome. Probably means your tumor's responding. And I think that it's great that you're continuing to exercise. The thing that I also tell patients is, you're getting chemo, you're getting radiation and chemo, it's going to make you tired. Mm-hmm. That is a side effect. Fatigue is a side effect of these treatments. So you have to use common sense. You're really tired, hey, that's not the day to do the exercise. And I also say you don't necessarily have to do it every day. Maybe you do it 2-3 times a week, 4 times a week, so you get some rest days in between. So it's common sense. It's all just common sense.
Does anybody else have any experience or have any comments? Anybody online? Michelle?
You've made me aware of what my mother went through. And she had lung cancer 3 times and lived 22 years from the first to the third. But when it came back the 3rd time, my mother was a small person. She normally weighed around 98 pounds, and she got down to 60-some-odd pounds. It was awful to see. There was nothing to her. But now I kind of understand what was going on, and I wish they'd know more about this kind of thing 20-some-odd years ago. So thank you for explaining it.
Michelle, did you have questions?
So Alan wrote in, and he just said that he had severe taste obstruction and painful swallowing, loss of appetite, dehydration, had to have IV fluids a lot. He did say Carafat and viscous xylocaine helped.
Yeah.
So he just wanted to tell us that. And then Rick had a question. It's a little off, but he had asked, he was on Remexatred and Carbo, and it was toxic to his kidneys, so he was dealing with his creatine going up, but he's now on Tagrisso and it's still rising, and he said he doesn't want to get off because it's working.
The Olympta?
Tagrisso is what he's on now.
It's still going up on Tagrisso? Well, he has to talk to his doctor. I don't want to give advice without I never give direct advice to a patient without seeing them. So I would say you need to talk to your doctor about that. I don't think Tagrisso that's going to be a major side effect of it. But Pemetrexed, that does happen, yes.
Okay, 2 questions. So one is I'm just gonna have to remember, but the first thing was, what was it that they said helped?
Oh, so for people who have bad radiation burn in the esophagus from radiation to the chest, what we do is, they call it a stomatitis cocktail. Carafate, which is a thing that's used for ulcers, coats the ulcers. You give viscous xylocaine, which is a local anesthetic, a topical anesthetic, and also Benadryl is frequently in that. It has some local anesthetic effect. But in fact, probably what you need more than anything is real pain medicine. So we usually would use like liquid hydrocodone, liquid morphine, liquid oxycodone, and some of these, like the morphine and the oxycodone, you can use an eyedropper, put it inside your cheek or under your tongue. It gets absorbed quickly like a nitroglycerin does for a patient who has coronary artery disease. And you take that 45 minutes before you eat, and then you do the stomatitis cocktail. Sometimes if it's really severe, you have to take a break from the radiation, because it can get to the point where people just can't swallow water. No, can't swallow water.
I actually remember that also happening to my mom, and I don't remember exactly what the cocktail was, but she would drink it and it would just numb sort of everything, and then she'd just try to eat as fast as she could.
Yeah, it doesn't last long.
No,
topical, where the pain medicine does.
Yeah, interesting.
So,
interesting. And then 4 things, because patients talk all the time about their labs, right? So, and having to come off of therapies, is there are there things they can do palliatively to help with those labs? Because patients ask all the time whether it's their kidney function or their liver function or something's off whack, and my doc's saying if it doesn't fix, I have to stop my meds. So are there things that they can do
Well,
preemptively?
not so much that they can do, but we can do,
There are.
which is reduce the dose. Reduce the dose, do dose reductions of the treatment, and then that might be okay.
Okay.
So that's one of the things we do. And then we get the other specialists in to help us. For instance, if you had a drug that's affecting the kidneys and you wanted to try to continue to give it, you give lots of extra fluids and so with the treatment and try to help to flush the drug out and protect the kidneys. But dose reduction or extending the time between the treatments sometimes helps.
And is there, because patients they ask this question all the time, are there certain foods they can eat that will help with that? Because I know there's all these books out there about, what to eat if you have this symptom or this one, and it'll help. Is it going to hurt if they eat these things? Is it going to help? Is it? Beets are a big thing. Beets.
Okay. I'll make one comment. If somebody has really bad irritation of their esophagus, don't eat acid things, don't eat tomato sauce, don't eat real spicy things, don't eat really icy cold or real hot temperature because it'll hurt like crazy. But any of the other foods to help with these symptoms, if they do, I haven't seen it and I'm not aware of it.
Okay.
Yeah.
Okay. Just curious. Anybody else before we move on? Yeah. Mike. I don't know if there's one back there. No, I know you're. No, sorry, I was asking for a mic. There you go. You can pass it back.
I don't really need one.
People online won't be able to hear you.
Oh.
Sorry.
Maybe that's good.
Yeah.
I was just wondering, you were talking about muscle mass or muscle strength, and my question was, is there a correlation between muscle mass and muscle strength? Do you gain muscle mass or do you gain muscle strength? And if you gain muscle mass, does that mean muscle strength as well?
The answer is we don't actually know the answer to that right now. But here's what I think. I don't think you can increase strength without training. I don't think you can increase performance without training. I think just pure muscle mass, maybe it helps a little bit, but I think you have to do training. And for anybody here do any exercise, a little bit, whatever. What happens if you get sick or you're busy and you can't do it for a month? Can you go back and do the same thing you were doing a month ago? I know I can't. No way. Just not going to. You're not going to be at the same level. And so I think that you have to do this exercise on a repetitive basis and build up, and you have to continue it. Because if you stop, it takes a long time to build up. Speak for myself. It doesn't take very long for it to go down.
Drop back down.
No.
Interesting.
So I think muscle mass, it's not a direct correlation. I mean, there's some correlation, but there are people that are real bulky muscles, and then there's sometimes, I think it's like baseball players or golfers or swimmers. They don't have big bulky muscles usually, but they got power.
Well, you see those people like doing those deadlifts or whatever.
Yeah.
They're not typically the ones that are doing the bodybuilding competitions, right? They don't.
No.
They look completely different.
Yes.
But yeah, that's interesting. I never.
So I think there's some correlation, but not a real strong one.
And I think it's important to point out that exercise as a whole, whether you're sick or not, I mean, it's insofar as your energy level and your strength and maintaining all that is an important thing. So it only would make sense that if you were sick, it would almost be more important, right?
Yep.
To help with your energy levels and all of that kind of stuff.
That's what we believe. And I think the other thing that we have to recognize as we age, we probably lose about 1 to 2% of our muscle mass every year. So you have to try to combat that. You have to do things to stay active. Otherwise, you're just going to become weaker, and that make people become frail. Their balance is impaired. And so maintaining physical activity doesn't have to be bodybuilding stuff. It's walking, riding a bike, maybe some core exercises, some lower and upper extremity things. Try to do some of that. But even if it's just walking is good.
That's great. Anybody else? Michelle, are we good there? Okay. So the next sort of bucket of this supportive care outside of the physical, and please, if somebody thinks of something about the physical aspect, even though we've moved on from it, you can still ask a question about it. But I want to talk a little bit about, in general, coping with a cancer diagnosis, because quite often you see patients that just completely shut down, they're depressed, they have anxiety. You know, what is the physician's, the medical oncologist's role in not only identifying that, but helping the patient to move through it?
Yep. So the medical oncologist's role is to be perceptive and realize this is happening. And this is an old paper. It was written actually by a neurologist. And so he says, you know, when we're dealing, this isn't just cancer, this is anybody who has an illness. There's what we call somatogenic component. The somatogenic component is the physical part. It could be pain, it could be shortness of breath, it could be loss of appetite. Those are the physical things. But then there is anxiety and there is depression. And these are all normal reactions, like, oh, he's depressed. Yeah, just heard he's got stage 4 lung cancer. You know, he's 42 years old. If you didn't feel a little bad about that, you wouldn't be normal.
Right, right.
You know, so that type of thing. So anxiety, depression, and I'll give you an example of something, and actually a patient years ago, a young woman with breast cancer, and she had bone metastases, and as far as I could see, they were pretty much in remission. But she kept complaining about the pain, the pain, the pain. Well, I think really when we kind of sorted it out, it was the anxiety that she had incurable breast cancer, and is she going to be there to raise her children? The depression that she had, that maybe she's not going to be there to see her kids grow up. And so if you're just giving pain medicine, you're not doing what she needs. She needs to see a psychologist, psychiatrist, maybe needs an antidepressant, maybe needs an anti-anxiety drug. So you have to sort that out. In this article that was written by the neurologist, he said he had a thing he called the SAD index. SAD, S was somatogenic, the physical part, A is anxiety, and D is depression. It would be like from analytic geometry where you have the XYZ axis and then you have a vector that comes out from that. Well, if you're thinking you just got to give pain medicine, but it's more anxiety and depression, you're not going to help. You're not going to relieve the suffering. And the suffering has to come from getting the team, you know, psychologist, medication if needed, and that's how you're going to help that patient relieve the suffering that he or she is experiencing.
So I'm just curious, before I ask my next question, did anyone feel early on today any of this, anxiety, depression? Anyone?
Oh, yeah.
Yeah. So, and then I guess, and then if, I don't know, I'm sure I know a couple people online who are probably saying yes. Did your docs ever talk to you about it or bring it up or notice it? Anybody?
Yeah, I mean, as I said before, I feel incredibly supported. From the get-go, I was referred to a psychotherapist, and today my oncologist referred me to a psychiatrist. And I'm open to all of it. Anything that, and I actually find it extremely helpful to be able to sit down and express my fears and anxieties with somebody. Yeah. I don't expect my oncologist to be able to do that. I mean, that's really, I mean, I think he recognizes that, but these other professionals, I'm profoundly grateful that they're there and that I can talk to them, and that's very much, as much a part of my treatment, frankly, as going to see my oncologist. So.
I think that's fantastic. So did you ask for it, or did he say?
Originally, when I first met my oncologist, he said to me, if I feel it might be a good idea for you to see a psychotherapist, would you be open to it? And I said yes. And then through the lung cancer support group, the psychotherapist was doing a presentation, so I kind of felt comfortable because I already knew who she was. Sure. And that just kind of opened up into that relationship, and I see her every 2 weeks. Yeah.
Great.
And well, for me, it was different because both when I was diagnosed with 2B and then the 3B, my biggest anxiety and my family's anxiety was the uncertainty. And although they referred me to some social workers and psychologists, what I really wanted was answers. And I found it very, very difficult to get through the doctor and just talk about, well, what's next? What do I do? And, how about a phone appointment? I wouldn't get even that much. And they said, no, you're just going to have to wait next week and see the doctor. And then through that whole time, the weekend, it's just sleepless nights, and it's brutal. And, I want to talk to someone that can give me some answers. I mean, it's nice to have the social worker talk to me about, maybe we can give you some medication or so forth, or, talk about this. But they couldn't answer my questions, and it was like talking to a hand. And so it was not much help. And I wish that oncologists and surgeons would be more open to talk to their patients, especially after a diagnosis, because that's when you need the answers the most, where the families are like, because I think what was ironic was that the surgeon, or somehow while I was like knocked out under anesthesia, the surgeon told my wife that, or my mother-in-law, something like that, that my chance of survival was something like 5%. And I'm not sure if they heard it right, but boy, oh boy, that just, can you imagine going through the whole weekend worrying, and then not sleeping, and then what do we do? That's the psychological terror that gets overlooked. And I know doctors, oncologists have limited amounts of time, but this is when I think they're most valuable. It's just right after that diagnosis, so that the patient can get some answers. What's next? And clear up this fog.
So if I'm hearing you right, what you're saying is if at diagnosis, he or she would have spent more time answering your questions and talking to you about some of these things.
Well, yeah, it's like your life is, you're staring death right in the face, and you're trying to stare at it by yourself. I mean, it's nice to have some doctor trying to help you out here and try to come up with, hey, this is your strategy, this is what we're going to do, don't worry, I didn't get any of that. It was like, I felt like a number. Next.
Yeah, unfortunately, and I think Michelle can probably attest to this too, we hear that over and over and over and over again. And we're grateful that we're here to help provide a service and be able to sort of help answer questions and provide that support, to patients. But for those people that, don't have that benefit, where do they go, right? To your point, where do you go for that help?
I felt so blessed to find this, this on, just from watching TV late night. I thought I was watching some sports programming. It was, then I was looking at the TV, and no, this is something about lung cancer, and I saw your mom talking, and then I had to come down.
Good.
To that.
Good. Well, we're glad you're here. Tekla?
That was exactly my experience, not with watching the TV, but the terror, the fear was unbelievable until I talked to Bonnie. I talked to her for 5 minutes, and she said, there are trials. There are things that we can do. And as soon as I thought there are things we can do, the terror dropped away. It was a complete lifesaver.
Yeah. Good. Thanks, Tekla. Anybody else experience that they want to share with that? So I think one of the things, and this is where when I'm talking to patients or Michelle or my mom or whoever's talking to them, it's about that waiting a week to have that conversation, right? And the stress and anxiety that ultimately leads to the depression that's probably already underlying, right? How can patients help manage that? As a physician who obviously does it different, how do you manage being able to do it different, and how can you maybe help them to have that conversation with their physicians?
Well, they have to be open to it, but one of the most important things we do is provide information. And one of the hardest things that anybody that has any illness, but cancer maybe more than others, is the uncertainty that you're facing. You know, you're starting out, you're getting staged. Okay, well, what stage is it? Is it somewhere else? And you're like on an emotional roller coaster going from day to day. So one of the things that we try to do is get people information in real time and try to answer their questions and try to tell them what we think we see and what we think they're dealing with and what the options are. Those are the key things. And you know, I'll be very blunt. If you have a doctor who does not spend the time answering your questions and is not willing, you know, it's like want to kind of rush out the room, you need to think about changing. I mean, I'm sorry. The doctor's job is to provide the information to you and take the time to talk with you so that you feel when you walk out, man, didn't even answer my questions. No, you should not walk out feeling that way. That's our job as physicians, to provide the information. Sometimes the information, the news is going to be bad, but it's better than, I believe, it's better than the uncertainty. If you know the news is bad, you know what you have to deal with, it helps you to make decisions. If you don't know where you are, you can't make a decision. You can't decide what you want to do with your life. So you have to have that information.
And we tell you guys all the time, you know, if you're with a physician who's not making you feel like at that moment during your appointment, you're the most important thing he's got going on, and he or she are not answering your questions and helping you through this process, to Dr. Bonomi's point, it's time to maybe find somebody else that would be a better fit. There are, of course, patients who don't want to know. They don't have any questions, right?
Well, denial, part of the psychological thing.
Right.
So you know that probably all of you have gone through this. Some people are more in one phase than the other, but Kubler-Ross wrote many years ago about there's anger, denial, bargaining, depression, and acceptance. And some people go through all those phases. Some don't. Some get stuck in one. But as physicians, we need to recognize that to help you to deal with it, because denial is not necessarily a bad defense mechanism. I heard a talk by a psychologist many years ago. Said, you know, we shouldn't be so brutally blunt that we just strip all that denial away. It's okay to have some denial, but not when it's affecting it to the point where you can't make good decisions for yourself. So it's a delicate balance. But denial, we all do denial in our life every day. You know, you don't want to believe this. You know.
Are there ways to treat? Because I think depression or denial is sort of a symptom of the, and I could be wrong. I'm just thinking out loud. Sort of a symptom of the anxiety, right, and the depression.
Yes.
Are there ways to treat that without medications? Because sometimes what will happen is now the patient's over-medicated and talk about exercise or cachexia or anorexia or eating or forget it. They're sleeping, you know, 18 hours a day because they're so over-medicated.
Right.
So are there ways other than medication?
No,
to treat?
I think what we just heard, you know, that you went to talk to somebody, and that helps you to feel better, right?
I totally agree with you. I have been with my therapist. She's teaching me coping mechanisms. It's not my goal to put one more prescription into my body. You know, I've had it. I'm dealing with side effects. I don't need more side effects.
Right.
So she is really helping me learn how I can deal with anxiety without prescription. And I do use those methods. They don't always work, but I think that they're extremely helpful. So.
I think talking is very, very important, and to have somebody that you feel comfortable talking to, and you may need somebody may need some medicine too. That's fine, but I think the talking is an essential part of it, and it can be with your oncologist, it can be with a psychologist, it can even be with your family members, but you need to be able to talk about these things because they're difficult things.
Do you guys find that talking to other patients and coming to groups like this, whether it's here or up at UCSF or down at Stanford, helpful in meeting other patients who are kind of walking the walk along beside you? Yes? Yes. I look back, you know, 6 or 7 years ago now when we started this living room, and it was, 3 or 4 people in the room, and it was kind of like, tell us what you want us to build, and we'll do it. What do you need? Help us sort of help you type situation. And I see what it's grown into. So I hear that, and one of the things I want most is to be able to get the word out even more about what it is we're doing here, and to hear you guys say. I mean, I know Tekla, I heard you say it, and somebody else said it about even hearing Bonnie, right? Her being a 12-year survivor. There's hope in that, right? Mm-hmm. And we all get online, and we, unfortunately, especially right after we're diagnosed, and we try to look and see what that diagnosis actually means for me, right? And either the data is not easy to understand or it's outdated, but what I think most people don't understand is you're looking at averages, right? And everybody's got to fall on one or the other end of that spectrum. And so I think in talking, I really think we talk here a lot about keeping your head in the game, right? And that being half the battle. Mm-hmm. And being able to talk to other patients, I think, go ahead.
I think you have to be very careful about going online. It can scare the crap out of you.
Yeah.
I mean, you go to a site like Inspire, which it can be very helpful. Mm-hmm. For example, you have certain side effects from Tarceva, like, what do you do? What kind of shampoo do you use? Things can be helpful. It can also be very, very frightening. Mm-hmm. So I really don't go online a whole lot. Mm-hmm. But the support groups are, for me, very valuable. I have a very good friend now that I met through the support group. We get together independently. It's a way to support each other and to help each other. I mean, sometimes people don't know about the resources that are available, and you can tell them. I look forward to my support groups. It's like a family. It's a community. So I find it extremely helpful. Yeah.
That's great. Anybody else have any comments? Are we still good online?
So one question.
Yeah.
Someone had asked, you were talking about the SAD index. They didn't know if there was an outline where they could find that or something related they could look up.
I wish I could remember the name. It was a neurologist who wrote this many years ago. He was at Johns Hopkins. And he pointed out, to me, it was kind of an epiphany to realize what we're trying to do is relieve suffering. Actually, my mentor tried to tell me that too. And it isn't just one symptom, it's all of this. And you have to address all of it, and you have to try to understand it because it's different for every person. I wanted to say one other thing too in terms of, going online. There's many, many good things, but you got to be careful. Some of it is not good information. And the other thing is when you look at statistics, when I tell patients, there's an interesting thing too. When I started out as an oncologist, virtually no patient asked what his or her prognosis was. Almost nobody. Now, almost all of them ask that. And I always ask them a question first, and I say, do you want to hear the statistics? Then almost all of them say, yes, I do want to hear the statistics. And then the next thing that I say is, these are statistics. If we have 100 people, this is going to happen to so many at this point, that's going to happen at that point. I don't know what's going to happen to you. Nobody knows what's going to happen to you until you get treated and see how you do. Mm-hmm. So you got to be careful. People read these things, I got 6 months. No, we don't know you have 6 months. We don't know what you have. Mm-hmm. But the statistics are maybe in that particular situation, 50% of the people aren't going to make it past 6 months. So it tells you how serious it is. It tells you how bad it could be, but it doesn't tell you what's going to happen to you. I think a lot of people walk away with, I've had patients sitting in my exam room and I'm talking to them and they're kind of uncomfortable. I say, is everything okay? Well, I'm 2.5 years out and Dr. So-and-so told me I had 8 months. You're not telling me something. Something bad's going to happen. No, you're fine. You're in remission. So it's almost like a sentence has been given to them. Right. So these are things, again, in delivering the message and giving the information, you got to understand that because it could really, that could add to somebody suffering awfully.
Right, and
Terrible.
Their anxiety and their depression and all of that.
Terrible,
yeah.
Yes.
Yeah, a lot of it's not so much the message, but how it's delivered.
Right, yes, right.
So, I'm sorry, Tina, were you going to say something?
Well, yes, I can say something. going back to the when you're first diagnosed, you feel very, very alone. Your family comes in, your friends come in, what can I do, what can I do? But they don't have lung cancer. And when you meet people that have lung cancer, it's like, oh my God, they're still alive.
Right.
Maybe I have some chance here. Maybe
Yeah.
I have some hope.
Yeah.
So why do you think I come back here every month to see my cancer buddies?
Do some of these symptoms, I'm guessing, throughout the treatment journey, particularly and I didn't really want to get into the chronic management yet, but do some of them, based on all the things that are available now, the supportive drugs that are coming down the pike, all that kind of stuff, and looking at chronic management of the disease, do some of these emotional and psychological symptoms kind of come and go, right, based on progression and what's next? And how can some of that be alleviated by the physician conversation about, hey, this is the plan B or C or D?
So generally, anxiety and depression are worse when people are feeling bad physically, and that's normal. If you're not feeling good, it makes you anxious, it makes you feel sad, and so controlling the disease helps to really alleviate those symptoms, and they do come and go depending on what the current status of the disease is. So that has to be recognized, but that's very normal. So.
And are there either at Rush or outside resources that you guys use to help support patients with some of the other issues, whether it be religious or spiritual issues, or how do I talk to my family about this? I'm no longer able to work, or their financial burdens.
Financial is a huge thing.
Yeah.
Cancer is a huge financial burden, and I think lots of medical centers are having people come to help families and patients deal with that.
Yeah.
That's a huge source of anxiety also.
Of course.
It's really bad. And the other big thing is getting drugs approved, the amount of time, and what you have to do. A lot of the drugs, they don't get approved, by the insurers, but the pharmaceutical companies frequently have programs where they can get it. It takes a lot of time and effort, and it takes our nurse practitioners do that. We have some financial people help do it, the social service. These are things that are very important because the anxiety goes up like this. Your copay's $3,000 a month. Like, oh, how am I going to do that? So,
I've actually talked to patients who have just foregone care because they don't want to put their family through the financial burden, right? And I know one of the services we provide is to try to help with some of the outside resources, be it industry or some of the other nonprofits out there that will help sort of subsidize some of those payments. Charlie, did you have a question?
Well, I was going to comment on the online paranoia, because my experience is more the opposite, because maybe because I may be younger than most people here, but since I became a friend of Michelle and looking up the Facebook of the lung cancer and everything like that, I just found so much good online support. I mean, just like the story about the immunotherapy, Bonnie was there, and just like all this money getting poured into something like that, where the dream of like not having to go through chemo and deal with those side effects and just have your own immune system beat this cancer is, it's more inspiring. It can be bad if you just go on your own, but I think if you're on Facebook, be a friend of Michelle or Bonnie, and then they have so much good stuff to come down the pike that it makes you happy to see what's going out there. So,
Thank you. That's an excellent point. Anybody else? No?
So the key is to have the right friends. Right?
Yeah, no kidding, right?
I have a question. I have to go back to that muscle loss, and I've gained some weight, but I do feel that when I'm sitting on hard surfaces, it's very hard for me to. I can feel that, like there's hardly any
not as much cushion.
Any cushion, and so I even went to the extent of buying like a pillow from Relax the Back store, and put it in, because most of the public places, they don't have cushion seats anymore. So I bring that. Is there a way to alleviate that? I've gained actually 4 pounds, and I'm very happy, and my appetite's good. But I think, sometimes I feel also my shoulder blades, they're kind of, like really hardly any muscle, or there's very little fat. So.
Okay. It sounds like your cancer is under control, so I'm guessing your muscle mass is relatively good, but I think this is a case where maybe some exercise would help that. It could be, walking certainly would help your lower extremities and areas in the gluteal areas. The trunk, I don't know, you don't have to do the heavy duty stuff, but there are some core exercises you could do. You'd have to, I'm not an expert in that, maybe get somebody that's in the physical fitness thing, locally here, work on it. But it sounds like you're doing well from what you described. So.
Oh, okay. Thank you. Yeah, definitely. I do try to walk
You do try to
regularly.
walk?
Yes.
That's good. Yeah, keep doing that.
Thank you.
Michelle, we good? Okay. So how important is it for a physician to understand a patient's goals when discussing palliative care? Because we're talking about maybe palliative care versus something like hospice, right? Because they're two different things. A lot of patients associate the two as one and the same, but they're really not.
That's absolutely true. So there are, we talk about goals of care, and one of the hardest things for me, and I think probably for most oncologists, is taking care of somebody. Your goal is to prolong their life and to enable them to do their daily activities, relieve their symptoms, and minimize side effects. And you get to a point in patients where we don't really have another option. And then the goals are changed to, now our goal is to make you comfortable the best we can. If you want to be at home, to try to enable you to be at home. And so that's a very hard transition. And I think sometimes other doctors who are around a patient and oncologist say, why is the oncologist still doing this? Well, we're trying to offer something to help you live longer, but then we get to that point where it's like, I think the risk of the treatment and the bad effects of it are starting to outweigh the potential benefit. Now we should concentrate on comfort. That's a very hard conversation, and one that we have, unfortunately, we have people living a lot longer, but we still have those conversations, and that's it doesn't mean we're not doing anything. Our goal now is just to make you comfortable, and we'll do everything we can, and we'll be there for you on the phone, because you're not going to be able to come back and forth to the office. But here, the other thing that I've seen over the years, and I think every doctor knows this, patients have specific things that they want to achieve. Just the other day, a patient we're now running out of things to do. We're going to concentrate on comfort. Do you think we can make it to our 50th anniversary in June? We really want to make it to that. I want to see the birth of my first grandchild. I want to see my grandson graduate from college. We had this trip we always wanted to do. So helping people to get to these major life events, kind of landmarks in their lives, is a huge part of what we do. And for many years, people asked me, how can you be a lung cancer oncologist? And of course, we didn't have too much to offer at that time. Well, for those reasons, we still help some people. And it's important for those people and their families to get to these events. And if we played some small part in helping to do that, that's very gratifying. It's really good.
So one of the things I want to talk about are the benefits of palliative care. Some of the things that can be sort of taken off your checklist, right, as to do when dealing with your cancer and your diagnosis and the treatment. And a couple of the things I have on here are, well, let me let you kind of talk about maybe some of the benefits.
Yeah, oh, sure.
And then I'll kind of circle back around.
So, the main benefit is to help you feel better. That's the benefit. If it's side effects from treatment, let's figure out how to minimize those. If it's symptoms from the disease, let's figure out how to minimize that. I mean, it might be let's say it's something, a painful bone metastases, you know, getting radiation to that can make a huge difference for somebody. It would make them feel a lot better.
Do you find that patients who are working with their doctors on treating sort of, or symptom management or palliative care have less severe symptoms? Would you say that that's a...
Yeah, I think so, because, I mean, well, and even that paper that we talked about earlier, Dr. Temmel, that early intervention with palliative care, managing symptoms, managing side effects, the patients actually live longer. They did better. So yes.
Yes. So a couple of things on the list and that I just think are important to kind of point out is some of these studies in the paper that Dr. Bonomi just talked about is, you know, less visits to the ICU, to the ER, less pain, less shortness of breath, less depression, less nausea, and then, of course, increased survivability. And they've actually done studies on this. So, like I said, I know you guys have heard me talk about this over and over and over again and the importance of making this part of your treatment plan and having this conversation with your docs. The proof is there that the benefit way outweighs not doing it. One of the things that we didn't discuss when we were talking about sort of the physical is hydration. How important is hydration?
I'm doing some now.
Yeah.
It's important because if you get dehydrated, it makes you really weak and tired. Terrible. So you have to maintain that, and sometimes, especially the young man who's getting the radiation and chemo, I don't know if you had to do this, but sometimes patients will have to come in extra time, and the outpatient, again, avoiding the ER, avoiding hospitalization, get some IV fluids, and obviously do the best you can on your own, but sometimes physically it's just not possible, so you need some additional fluids.
Right. So this is kind of circling back around to, and I think we've said it over and over, but I want to hear you say it one more time.
Okay.
Who should get supportive/palliative care, and when should it be offered in the cancer journey?
Every cancer patient should get it, starting from day one. And again, it'd be delivered a lot of times by your initial team, the oncologist, nurse practitioner, treatment room nurses, and then we bring in the palliative care specialist as needed. They say, hey, you know what? We're not controlling the symptom as well as we'd like. Let's see if they can help us with this.
So we've talked about a palliative care specialist. Can we talk a little bit about who is on sort of this team? So it's sort of usually typically, I think, led by the medical oncologist. And then who might also be brought into that, and what specifically is a palliative care specialist?
Well, I mean, palliative care specialists are general internal medicine doctors who take an extra year of training in that, or 2 years. But more and more, in fact, some of the folks we work with, one is actually a pulmonologist and a palliative care doctor. So she knows a lot about emphysema, chronic bronchitis. So she sees a lot of our patients who are having trouble with breathing. And then we have another oncologist, very good. She's trained in oncology and palliative care, primarily focuses in GI oncology, but we send a lot of patients to her for management of nausea, vomiting, constipation. We didn't talk about that. That can be a huge symptom for a lot of patients and problem. And and pain management. So we think more and more the palliative care doctors are going to be more specialized. It's not just palliative care, you take care of heart patients, cancer patients. No, they're going to be oncology palliative care docs, pulmonary oncology palliative care doctors, because they understand the disease, that particular disease, better because they've got training in it. Whereas somebody who's a general internist and a palliative care doctor, I mean, they can be very effective, but they can't know the same amount as somebody who was trained in pulmonary, trained in oncology. So I think they're really starting to see super subspecialization within the palliative care physicians.
That's great. So I'm gonna, we have a couple of minutes left for TV time. So I'm just gonna say some thank yous so I can make sure to get that in, and then we can go ahead and continue the program. Obviously, I wanna thank Dr. Bonomi for coming out here and sharing this wealth of information with everyone. I wanna thank our presenting sponsor, Helsin, for ensuring that this program was had and rolled out. And then the multi-sponsored support we received, obviously, from Genentech, Lilly, Novartis, Biodesic, Celgene, BMS, Boehringer Ingelheim, and Merck. The Office Bar and Grill for Pasta Tuesday. Peninsula Television, obviously, for coming out and providing this service for us so that those of you online are able to participate. And then I want to give a heads up that next month, Dr. Raja Mudad from University of Miami will be coming out to talk with us. Thank all of you for being in the room, everyone for tuning in online. I'm Danielle, for those of you who don't know me that are tuning in, and Bonnie will be here next month. So with that, I think, Gianna, are you going to give a couple of updates on next events? Oh, Sally, will you hand her the mic? Sorry, thank you.
We are wrapping up our spring event series for our 5K. So our next 2 races are Sacramento on April 30th at North Natomas Regional Park, and Chicago on June 26th at Lincoln Park. So if you live nearby and want to come join us, we will be there. Upcoming grassroots events. We've partnered with Upstage Lung Cancer for the 3rd year in a row, bringing the singing concert to Boston. This year the event is held on May 20th at Dana-Farber. If you would like to purchase tickets or want to host your own fundraiser, you can come talk to me. And then lastly, we have bibs available for the San Francisco Marathon on July 31st and Disney Half Marathon Weekend in September. So if you want to run any of those, you can talk to me as well.
And we certainly don't expect lung cancer patients to run marathons.
We do not. Friends, family,
anyone,
caregivers,
yes,
anyone.
who knows anybody who
Yes.
might be interested, that would be great.
Not
great.
patients.
Thanks,
Thank you.
Gianna. And so, sorry about that little logistical thing we had to do there. Linda, did you have a question?
Oh, yes, I do.
Sorry.
Doctor, I just have one question of confusion here. When you hear someone's in remission and someone is stable, is that the same thing?
You know, a stable remission means that tumors shrank by a certain percentage. There's a definition. And stable means it didn't shrink that much, but it's not growing and no new things.
Okay.
And in general, in non-small cell lung cancer, stability or remission probably are pretty similar in terms of the outcome for the patients.
Okay.
Some of the people that are stable for a long time, but they didn't meet the exact definition. Maybe they had some shrinkage of their tumor, but it wasn't enough to be called remission. But in essence, it's just it's the same thing. Their cancer is controlled. Mm-hmm.
Thanks, Linda. Does anybody else have any questions about anything? No? Online? No, we're still on.
Okay, so do you have any advice on how to get palliative care when your patient's oncologist doesn't seem to get it?
Not good advice. I guess all you can do is ask or try to seek them out on your own. I mean, that's all you can do. It's I think some oncologists are maybe resistant to it sometimes.
Yes.
I think even it's this whole sort of era of beginning this palliative or supportive care at the beginning of treatment is a new sort of the landscape is very new. Mm-hmm. So I think there's a huge benefit in you guys talking to your own docs about it and making sure that they understand what your needs are and what your wants are and what your symptoms are. Mm-hmm. And that's a big part of it, is that conversation. Anybody else? No? Okay. Now I want to give a real huge big thank you to Dr. Bonomi for coming all the way out here from Chicago and speaking with us. I think, like I said, you guys haven't heard the last of supportive care from us or the importance of it. So, and as things are approved, you'll definitely hear more and more and more and what it is you need to talk to your docs about. Because we truly, truly believe in it. And Dr. Bonomi, as you can tell, is passionate about it and ensures that all of his patients are getting 360 degrees of care. So not only treating the cancer, but treating the whole patient's symptoms and all. So you should all expect the same thing. Yeah.
Yeah, just a question.
Sure.
Is your terminology supportive care, is this something that's just you and Bonnie are pushing, or?
I think a lot of people are interchanging it.
Is there a move to get away from calling it palliative care?
Well, I think you'd have to, I think within the medical community, it's sort of a, I don't want to say it's 50-50, it's probably 70-30. I think a lot of people are using them side by side, like they're usually still starting with palliative and then / supportive care, and then having a conversation about what that looks like. And I'm going to ask you, is it because your idea of palliative care was more end-of-life care, or that comfort
Yeah, I mean, that's the
care?
way it's traditionally been used.
Yeah.
And so there's such a reaction to it.
Yeah.
That,
Yes.
I know when Tekla first started her treatment, and it was specifically related to chemo, but the doctor said, you know, if anything has happened in our treatment, it's that we can deal with the side effects almost better than we can deal with the cancer. And so there shouldn't be much reason why you need to suffer from this.
Right.
And so if you are, tell us and we'll deal with it. And it was such a positive message that it was really.
Dr. Bonomi, do you use palliative / supportive? Do you interchange them?
We just, I think that, it's a specialty, palliative care is a specialty, so we use palliative care.
Yeah, it's really interesting. I think that kind of it goes along the sort of misunderstandings about clinical trials and what those mean as well, right?
Yes.
People are still thinking they're getting placebo versus
Yes.
study drug, right? And so there's some challenges that are associated with it. And I think you guys can help with that when you're talking with your doctors about it. Organizations like ours can help in really defining what palliative care looks like and what it means and what's available to you, what you should be asking. And then, of course, the conversation, most importantly, the conversations that you're having with your physicians and that they're having with you about what it is and what it means.
Kind of what we hope people will develop is the concept that palliation is a process. It's a process that starts from day one. And again, at the far extreme, and maybe where we talked about the goal changes from, sorry, we don't think we can do anything to make you live longer, but we can help you to be comfortable. And that's all our efforts are going towards that now. That's the extreme end. But at the beginning, it says, let's make sure your nausea isn't too bad. Let's make sure that your swallowing is, palliated so that you can maintain your nutrition. So it's a spectrum.
And I think it's going back to your quote that you started with, which was to relieve suffering and pull in meaningful life. And I think that's important because, who wants to have cancer and suffer unnecessarily on top of the anxiety and depression? It's like this big vicious circle. It's like if you don't treat the whole thing, it all feeds and adds to all the other things being worse.
Yes.
If
you live longer but you're miserable, is that worth it?
Yeah.
Probably not.
But you can't get out of bed and you're vomiting all the time and
right.
you can't, no.
So it has to be a balance. The treatment has to be tolerable and so that you can live your life, and then hopefully it's also prolonging your life.
One of the things I didn't ask, do you think that incorporating palliative care into the treatment plan of patients helps them to chronically manage their disease to some extent, to a greater extent?
Yeah, I think it probably does. It gives them another team member that's there for them and can help them with things. And I'm a strong believer in this Japanese proverb, none of us is as smart as all of us. And, that's what this philosophy is. The team, people, how about doing this? Oh, yeah, why didn't we think of that?
Yeah.
So that's what happens when truly none of us are as smart as all of us. We're not.
That's great. Takes a village. Right, go ahead.
Can you hear me?
I can, but people online can't. Sorry, babe.
I had a question, but it's more for the foundation. Have you thought of, I don't think it exists yet, but doing like a group therapy for just the patients? Like a support group, because what she was saying was extremely important. I feel like my mom looks forward to coming here and seeing the patients and getting to talk to them after the meeting. And I just feel like they have a connection and like they actually understand each other. She can't exactly tell us different certain things, but I think it's I'm just curious about like the plans that maybe Foundation has
Yeah,
in
yes.
regards to that.
So once a quarter, we try to have a non sort of key opinion leader educational aspect to it where it's just around the room. So it's mingling, it's talking, it's having conversations. We, of course, encourage patients to stay later and to come earlier. Patients will show up at 5 and leave at 9 sometimes, right? So that would be Tina for sure, here till 9 o'clock. But yeah, so the answer is yes. This room is available, 365 days a year if patients just want to get together and meet themselves and they need a place to do it. So, we're open to all of that. But once a quarter, we try to make it where it's just patients. So we can have those deeper dive sort of conversations into, where you are in your disease, what your questions are, what your concerns are, what you can learn from one another. Yeah.
Thank you.
Sure. Charlie?
I was just going to kind of echo some of the sentiment the other gentleman was talking about. There's such a strong negative connotation with the word palliative care. I think cancer support care is more appropriate for people because it's not negative and it's more like, oh, cancer support care. When you hear palliative care, you're thinking, I'm going to die. Oh, now hospice, you start thinking about all the stuff because that's what my mom went through. And I'm like, oh, palliative care, hospice, I'm going through it. But when you say cancer support care, it's more positive, So I hope they change the name and it resonates better because I think it gets the message out better. Because when you say palliative care, some people may not want to listen to what you might have to say because it's,
Yeah. Palliative care is not specific to just lung cancer, right?
Yeah, yeah.
It's oncology in general. We should do
all of medicine.
all of medicine.
Oh,
Yeah, no, you're right. You're right. We should just do a general survey and have people take a vote and then petition the medical community and the government to change what they call it.
Yeah,
It'll
it makes a
change
big
rapidly,
difference.
but I
Right.
agree with what you said.
Yeah. Anybody else? Okay, one more round of applause for Dr. Bonomi.
Thank you.
Thanks, everybody.